patience.
I like that. Yes.
Okay, GovOps back on Friday the 12th for the very last time. We have an ever-changing group of folks in here. We're going to talk a conversation about reference-based pricing. You all might recall we talked about this last year. We have had a request from the Vermont NEA and the Vermont EFTA for some funding to do an analysis of the possibility of reference-based pricing for our state and teacher healthcare plans. So what we are doing.
Somebody will explain what that means.
Yes, so actually, we're gonna start with Tim Ash. Hi, Tim. Thank you for your patience. Tim, as you know, works in the auditor's office and they have done a lot of work on this issue. So I think having Tim explain what it is, or remind people what it is to start with would be helpful. So Tim, I had Olivia post that email that you had sent us last year.
Yeah, if possible, if you could pull that down, but then I sent a more formal document that I think Olivia did post.
Okay, perfect. Thank you. So why don't you take it away and just give us an overview would be great.
Sure. Tim Ash, Deputy State Auditor for the record. Good afternoon, everyone. I'm gonna, if it's okay, I'm gonna take like between 5 and 7 minutes just to queue up and remind you what this issue is, but I'm not gonna go into too much detail because we're not here advocating for the language, but might be able to help just set the table for you or reset the table. Back in 2021, our office did not an audit, but we did sort of an analytical report about reference-based pricing, among other things, as strategies to address the growing cost of the state healthcare plan. We had done work around price variation in healthcare, meaning same service at different facilities being reimbursed different amounts, and kind of married that issue with the question of whether there were strategies which might be able to help address the growing cost of state employee healthcare. I'm going to pull up some slides in a second, but just, and I hope I forwarded this to you in an email, the two things that are updates, if you will, from the last time you convened to talk about this is that the cost of the state employee health plan has jumped a pretty staggering amount in the last year. It rose $27 million, but from calendar year 22 to calendar year 23. So that's the biggest one-year growth, we believe, probably in the state employee health plan's history. That does not include pharmaceuticals. That is for medical and behavioral reimbursements for those services. The plan only increased the number of lives covered pretty marginally in that time. So it's not being driven by a huge influx of state employees or dependents who are covered by the plan. The other update is that the state of Oregon, which followed Montana in following a particular model called reference-based pricing, now has enough track record for their program, which serves both state employees, but also teachers and I believe municipal employees. And they found that in 1 year, it had saved $112 million in a system that covers about 10 times the number of lives as the state employee health plan, just for some perspective. So states have experience. There's evidence to support the tool that I'm going to talk about. So I'm just going to pull up, I've basically cribbed some images because I think just quickly walking through them will cue up the discussion that the other witnesses will have. And I see that Senator Clarkson has a question, so I'll hold on.
Tim, thanks. It's helpful. The 23 million or 23 million, right?
27.
27. What percent growth is that? Because, we looked at 16.4% growth in teacher healthcare costs, benefits. What percent growth is that for the state employees?
Well, in order to not screw up my computer here and have too many things, I don't know, take 27, divide into 170, and you'll get the percent.
Okay. I don't know where they were starting from. So, yeah, sorry.
No, and again, that, we focused on what we believe is more within the state's control and utilization, which is the medical and behavioral, not pharmaceuticals, which are prices largely set, externally.
Right.
So the actual cost of the plan is greater than these numbers, but these are the medical and behavioral, expenses associated with it.
And it's growth.
15.9%.
15.9%, nice.
So
So,
pretty consistent with the teachers, it sounds like then.
yeah,
Let me just, pull this up.
And he has it in his comments too.
Yeah, if you look on, our website,
Yeah, exactly.
here we go.
All right, so this is where we're at. Image from our report, which ran up through 2019. At the time in 2021, we didn't have the 20 data in 21. What happened pretty predictably in 20, utilization in general was down for many Vermonters. So you see that drop, but then it just picked right up where it was left off. So this just gives you a sense of why our office was interested. And to put it in some perspective, the annual cost for the payments for the state pension system is only about half of this. Now, obviously, the long-term obligations of the pension justified the fairly intense work that members of this committee and others did on the pension reforms. But on an annual basis, this is far, far greater expense. Historically, I think there's been a little bit of shoulder shrugging about this as if there's nothing that can be done. And we wanted to see if states had deployed strategies. I mentioned that we had done some work on price variation, and we were trying to incorporate the themes from that work into the state employee health plan. And this is a highly simplified but realistic sense of why there might be opportunities through something called reference-based pricing to try to make some savings for the state employee health plan. So this is, nice. We actually customized this little clip art guy with the
Love the bandage.
bandage.
Easter hat or band.
Yeah, we should have trademarked that. But so these are 3 actual hospitals in Vermont with the actual amounts that would have been paid, not prices that are on like a retail price, but these are the actual prices that Blue Cross would have paid on behalf of state employees to go to 3 different facilities for the same service. And you see that the actual amounts vary pretty significantly. That's at the core of what states who have tried to tackle this, what they're trying to exploit is to say, why are we willing to pay dramatically different and usually higher prices for the exact same procedure? Do we want to intervene and try and do something about that? Spreading it across sort of the whole system, taking 2 procedures that were in our 39 procedure sample. These are all representative of individual Vermont hospitals for 2 different procedures, CT scan of the chest and echocardiograph. This is dated from 2019 data. And as you can see, the prices that are actually paid, the amounts paid vary quite significantly. And it's also important to note, and this comes from our report, that not all hospitals are always the high price option for every procedure. You can see here that Hospital C, while the highest in the first chart, drops to almost the lowest in the second. In the second chart, Hospital F drops pretty significantly on the first. So sometimes I think people think, attempts to discuss price variation, it's about one hospital must be the problem. And in fact, it's really about trying to address procedures being provided at very high cost wherever that's occurring. In the 39 samples we had, this gives, just to explain this, it's talking about basically the spread between the typical price paid at the different providers and how great that spread was. So if you look at like the outpatient column in the 3+ times, that means that for 18 out of the 39 procedures in our sample, the typical price paid to the lowest and highest paid provider of that service was greater than 3 times for 18 of the services, meaning frequently there's huge variation in the prices being paid for the same service. The Green Mountain, and this is
Yes,
Yeah, I see.
Senator White has a question.
So I'm just trying to understand, and maybe this is just a way too obvious of a question, but you don't really get to pick what hospital you get things done in if they're hospitals that are farther away from you than others.
Right.
So do you, in your samples, are you looking at hospitals nearby each other, or are you looking at hospitals far away? Or,
in the report, which is the person who was the lead author, Fran Hodgins, who unfortunately we lost, but fortunately she went to AHS, so the state gained her. Very, very talented. This looked at 39 procedures at all hospitals. So every hospital in Vermont is a part of the report. It's just
see a part of the report?
say that again.
Is so most folks use Dartmouth Hitchcock.
Well, in your
area.
Yeah.
not. in
Yes, no,
Vermont.
I'm aware of that, I apologize.
I'd have to double check whether they were in there. I'll have to double check and get back to you on that. But the key point is that we weren't singling out particular hospitals. We were trying to capture the sort of high-priced, high-volume, great variation procedures, because that's where the opportunity might exist to try to use reference-based pricing or some other strategy to find savings in the plan. But I'll get back.
High-risk procedures that you used.
Typically, they would be non like
Part
I
of
think I'll send you the list of the actual procedures. I can get you the list and you can take a look.
Okay.
So the Green Mountain Care Board, this is now dated at the bottom. This is the citation is about 10 years ago. The legislature, I believe, directed the Green Mountain Care Board to hire Wakely to try to understand what drove price variation. I'd have to go back and look at the methodology, frankly, but the green and blue are basically the things that they could explain, either on the provider or insurer side, to explain the price variation that they found. The red, what they call unexplained variation, basically means they couldn't come up with a good reason why the price was different. So that might mean that it was just negotiating prowess. It might mean that it was some historical baked in reimbursement scheme that no longer makes sense, but has just been there and built on over time. But this gives some perspective when, some critics of any strategy to intervene on lowering the amount paid for hospital services will often talk about the explanations you'll find in green and blue. But it's the examples in red, or that chunk of these bars, it's the red which is the opportunity for savings that would not violate those legitimate reasons why you might see different prices being charged. So looking at the state of Montana was why we focused on reference-based pricing. Some of you might be familiar with NASHB. NASHB is a national association of which I think maybe DEVA is a member. It's a kind of a state clearinghouse for healthcare policy. And they had done a webinar on Montana's efforts to use this tool, which is why we were intrigued. They had an independent analyst look and found that they'd saved roughly 48 million over a 3-year period. And that is for a plan that covers about 28,000 people, if I'm not mistaken. So a little bit larger than Vermont's. What they did, I want to highlight one thing here. If you look under services covered, this is a key thing. They faced the type of criticism that comes up anytime a strategy like reference-based pricing is presented, which is, what about the small hospitals? Anything we do might, cause harm to them. They have, I think, responded to that by just cutting out critical care hospitals from the program altogether. Oregon did the same thing. I just want to be upfront with that. So Oregon and Montana's strategies were not inclusive of every hospital within their state. They did not include critical care hospitals. In Vermont, that means I think 8 out of the 14 are considered critical care. That reflects a fairly low percentage of the overall spending on the state employee plan. But in terms of the number of facilities, I thought it would be good to just flag that for you. Here's the way we did not do reference-based pricing the way the language that you're looking at today asks for an analysis. We did not try to tie to Medicare, frankly, because we did not want to incur the expense and the level of technical depth to do it that way, in part because we were just trying to do almost like a proof of concept about how might this look in a state with the state employee health plan. So what we tried to do was use something called the median price and look at these procedures and say, okay, what is the midpoint amount being paid to each of the providers for these procedures? By virtue of doing that, we then took the middle provider, the provider who was being paid typically the median amount of all the providers in the state, because then we knew that it could be done by at least half of the providers were doing it at that price or less. So it's a perhaps somewhat oversimplified means of doing the analysis, but for the purposes of queuing up the questions, we think it was a very helpful one. And this is an example where you see that if the state health plan was to use this benchmark of the median price, that would immediately say to these other providers, we are only paying you, in this case, the $2,615, because we know that it can be done at that price. And the savings is effectively the difference between what they had been paying, that new median price times the volume in a particular year. Now, some people might say, well, what about these people below the line there? You know, the ones who were charging less, will they just charge more? And will that offset some of the savings? The answer is yes. If they were to do that, some of the savings might be eroded as some of these providers increased their price. As you can see, even if that were to occur fully, it still would produce savings just for this one procedure. And in the other states, I do not believe there's been evidence that that's been the reaction of certainly not all, but even many of the hospitals who were the lower priced providers. Again, I don't want to dwell on this stuff because frankly, it's a level of detail that I'm happy to follow up with you later. So using that analysis, using that median price approach, we found that for just the 39 procedures, it would have saved 2.3 million each year, and that extrapolated out across all the procedures. If we were to extend it to all of the procedures that state employees use at these facilities, it could reach above 16 million each year. That's based on the 2019 figures. So assuming everything else was held constant, it would presumably be a little bit higher than that now with increased prices. And then the last thing, this is just Fran had produced using data from DHR. She took the zip codes associated with every state employee, excluded the out-of-state zip codes, people who live outside of Vermont but work for the state, and layered it in with the hospitals so that you've got this overlay. It's actually a pretty nifty way to look at it, because then you get a little bit of a flavor for where that volume actually is occurring. I mentioned that there are 8 critical care hospitals, and frankly, most of the state employees, that's not their most proximate healthcare facility for hospital-based services. So I'm gonna stop sharing there because I could talk, frankly, for quite a long time. I think I probably said as much as you probably need from us, although I'm happy to answer questions.
No, very helpful.
Yeah, thanks, Tim. And did you send those slides to Olivia already? Okay.
I didn't, but I will. They come glammed up.
But the bandage is there.
Yeah, the bandage is there. If you could send those along, that would be great. That would
Yes.
help.
Easier
There's a
on
memo
it.
from your office on our website, but having the slides too would be great.
Okay.
Committee, do you feel like you have at least a base understanding at this point?
I have a
Okay.
base.
It came back to me.
Okay,
I
awesome.
was like, oh,
Very helpful.
Tim, you're a good teacher.
You did as we needed. So that's really great. Thank you for that.
Yeah, very helpful.
Yeah, thanks. Now we're gonna hear from, so what we're talking about is not implementing reference-based pricing. What we're talking about is doing is potentially supporting a study on whether it would be helpful for the two plans. So if you guys want to just
Yeah.
And this doesn't exist in a bill, this exists as an idea.
as an idea
It was-
for the budget.
Yes,
But we
recommendation.
do have But what we do have, and I just asked Olivia to post it, I got language from Colin, that's the language we're talking about, right?
Yes.
So Olivia's posted it and has printed out copies for the four of us. That is, so Devin, it's on our website now, I'm sorry, if it wasn't there before.
But you know, right now, people do this individually to make decisions about where they're gonna have certain procedures done, and it's a ton of work. People,
I know, it's crazy.
All right, so we have,
Well, and to your point, sometimes you can't.
Yeah,
Sometimes the hospital you've got and the price they're charging is what they
yeah,
are.
and your
Yes.
plan is your plan, and
And well, I know like people who've gotten wrist surgeries who have shocked.
right, that's what I mean, shot.
all right, Mark, why don't you
Hi,
take it away, give us your pitch,
so just for the record, I'm Mark Hage, I'm the Director of Benefit Programs at the Vermont National Education Association. I'm also a trust administrator for the Vermont Education Health Initiative, VHI, which provides healthcare benefits and other services to 35,000 school employees and their dependents, active and retired, largely public, but we also have private school institutions that are part of our pool. The Vermont State Teachers Retirement System is also a member. I have a great pleasure of being with my fellow advocate, union advocate today, Norton from VSEA, and our two pools combined serve approximately 60,000 Vermonters. State employees, school descendants, active and retired, bless you. So, as previously noted, and Mr. Ashley had a very fine foundation for Adam and I, we are looking for support to create a reference-based pricing task force. I'll talk about its composition in a moment. And this task force.
Allison
This-
needs that reference based.
I'm fine, it's just something hit
You
me.
start talking about medical care and you start sneezing.
Yeah, exactly.
Hey, listen,
So we're also seeking funding for this task force to contract with a Medicare repricing vendor. These are entities that run inpatient and outpatient hospital claims through a very sophisticated technology and reprice those claims benchmarked to Medicare rates. Now, Mr. Ash made reference to the fact that their methodology is different from the methodology we would be pursuing with this proposal. And so again, just to reiterate, in our proposal, we would be asking this repricing vendor to tell us what we are paying for inpatient and outpatient services today as a price relative to Medicare. So let's say the repricing vendor comes back and says, these particular services at this hospital, on average, are paying 250% of Medicare rates. Here is what you would have saved if you had paid, coming to Oregon's example, 200%
right,
of Medicare rates. Or to Oregon's example, 185% of Medicare rate for out of network care. And those target points for this analysis can be set at any number of levels. We are particularly interested, as Mr. Ash spoke to, about the Oregon model. A report was published just last month in the Journal of Health Affairs, which concluded or projected that savings in the first 2 years from Oregon, and the Oregon pool, by the way, covers about 300,000 lives. And it's just public sector employees who are impacted at this time. So we're talking school employees, state employees, university and state college employees, and other public sector employees and their dependents. So this report projected that the savings in the first 2 years would amount to $107.5 million. An independent audit of the Oregon project to date concluded, using actuarial methods, a different methodology for analyzing savings than the Health Affairs Journal folks did. It found that the savings for the first 2 years in the neighborhood of $171 billion. So somewhere between those two figures, I suspect, are the real savings. Whatever the number, it is significant.
it's big.
And it certainly has captured our attention. I was unaware in 2021 when I began researching reference-based pricing for the first time, before Adam and I really began to dive into it, that the auditor's office was actually well ahead of me. We were actually talking to some of the same people without knowing it. And their report and their research was really inspiring. Even though it was a different methodology, it was, if you will, proof of concept.
Right.
And it drove Adam and I to begin research even more deeply. The task force would consist of 2 representatives in our proposal from VSEA, 2 from Vermont NEA, a representative from the Human Resources Department, and a representative from the State Treasurer's Office. When Adam and I were contemplating this, and in fact, we were here almost exactly 1 year ago talking about this, we reached out to RAND, because RAND has done some really pioneering work in price analysis and hospital transparency in respect to costs. And we said, if you were to provide us with a comprehensive Excel file report that did the work we're talking about today, what would that cost us? And they said, we can do this work for $15,000. We thought, okay, if that's what RAND thinks it can do it for, we're comfortable coming to the legislature and asking for that amount of funding in order to do this analysis. And to the chair's point earlier, we are not asking that reference-based pricing be implemented. We want to see what the promise of it could be for our public sector schools.
Do you have that in writing from Rand?
Yes, I do.
Okay, that, if you could send that along, that'd be helpful.
Happy to. Actually, I provided it to Nolan yesterday, but I can provide it to you
Okay,
as well. I want to also just give a shout out to Montana's work. Marilyn Bartlett in Montana was really seminal in helping to shape my thinking on this. Adam is also very familiar with her work, and we've both spoken with her. And the savings in the first 2 years of that reference-based experiment, if I can call it that, was nearly $48 million. That we're talking lowering costs by $48 million. There has been no increase in state employee premiums in Montana. And when the project began, there were 31,000 state employees, I believe. There was no increase in premium contributions by state employees for 7 consecutive years now. 2017, 2024. There's been no increase in the state's contribution for the same period. I also reached out to one of the chief negotiators who worked with Marilyn Bartlett on this project, and they negotiated hospital by hospital for those that were affected. Oregon, as Mr. Ash noted, established their RVP rates in statute. So I talked to one of the negotiators in Montana, and very nice guy. And he said, one of the beauties of the system is that you can hone it to specific hospitals. You can look at each hospital's data, and you can determine what is a fair, objectively fair price for these services benchmarked to Medicare's rates. And that was impressive to me, and that's what they did in Montana. In fact, Montana set a range for their RVP reimbursements. It was 220 to 225% of Medicare for inpatient care and 230 to 250% for outpatient hospital services, respectively. Other states have also been exploring reference-based pricing, doing it differently for Montana and Oregon. But again, I think all of us are struggling now with the question of how do we rationalize hospital prices? How do we arrive at a price that is fair? I want to really stress this, that is fair to hospitals, because they need the revenues they need to keep their doors open, provide high quality care 24/7, but it is also fair to, in our case, public sector employees, but I would argue for all vendors. And these other states that are now have passed statutes are North Carolina, Colorado, Washington State, and Nevada. North Carolina actually wanted to do it for its entire hospital system. Got a lot of pushback. There's a lot of very powerful hospital conglomerates in the state. And so they contracted with independent hospitals and negotiated their RVP arrangement, much as Montana did. So we think this is a project that will allow us to gain greater insight into what we're paying, benchmark to Medicare, and if there are rates ultimately that are fair both to hospitals and for public sector workers, and will bring down costs, and also make these prices far more transparent and standardize them to the greatest degree possible.
Okay, Senator Bielski.
So I was just wondering, and this is from my recollection of from the pension conversations that included state employees, teachers, and municipal employees, why are they not a part of this conversation?
There's no reason they couldn't be.
Okay.
Adam and I sort of started this ball rolling. We talk a lot about healthcare costs, as you can imagine. And our worlds intersect in different ways as well outside of that. And we started talking about the auditor's report. Then we started talking about Marilyn Bartlett. One thing led to another. We said, why don't we start collaborating on this and bringing this to your attention and others. There's no reason why municipal employees could not be a part of this conversation. They certainly are in Oregon. They're covered in the Oregon statutes, and I understand they're part of these very large pools. So yeah, we can certainly.
Yeah, and my only thought, like I said again, was when we were talking pensions, it was those three buckets. And so this
Sure.
seems, I mean, I'd love to see us move on something like this for every Vermonter, but it's starting point.
Hey, fuck, so why stop at public safety?
I mean, I agree.
Yeah, on the municipal.
Adam,
Oh,
wait
yes.
a second. If you wanna talk, that's fine. It just, if you wanna come up to the witness chair.
Sure.
Yeah.
On the municipal front, there's no statewide municipal health plan, and a lot of states have entire public sector pools. This state
Gotcha.
is not one of them, and their employers with generally less than 100 employees, so their employees are in the exchange. However, some states are using reference-based pricing for public options on their
That's right.
exchange, which we don't have here either. But then I think Nevada and North
I
Carolina.
believe
both do
that is certainly.
If we moved something like this, my guess is we could attract a lot of municipal. I mean, we could attract a lot of people to join some gathering on some umbrella, your which they could all
Well,
cohabit.
so the ask is just for the $15,000 and some kind of study. I can tell you, and Colin studied this a while ago, and I just haven't had a chance to actually absorb it, but we can't give JFO this work, because of a lot of things.
They are
So
overwhelmed.
I would have to rework this a bit, and
Sure.
see if I can come up with something. I also want to, since she's been super patient and stuck with us, and see if Devin wants to, if you wanna say anything, or not, I don't have to, but,
Before she does it, can we just clarify how many lives are we talking about together?
For our two pools, about 60,000.
60, that's what you said that. Yeah.
okay. Welcome to my morning committee, everybody,
Did the VSBA have customers? Or you always?
so
Devin, you wanna
this
sit here?
is this was the VSDA's, is this still what you guys, or do you have something different?
Only just a couple points.
Okay, I'm sorry.
Oh, not-
Sorry,
yeah.
I didn't realize, it. I'm sorry.
Not a big deal, it's
Um,
mostly joint, I just wanted to bring up a couple more points. Hi, Adam Norton, Vermont State Employees Association, strategic analyst. Why we should do the study this year, as opposed to another year. We're piggybacking on work Rand is currently doing. If we wait till an off numbered year, the price is gonna be about 65.
From 15,000 to
Yeah.
65?
Well, that would be this year, probably be more,
Okay,
but yeah.
all right, well,
That makes no sense.
And just to compare and contrast with Montana, where they've had 7 years of no premium increases for their state employees, our premiums are up 37% in the last 3. And most of my work out of the session, I'm working on contract negotiations, and as it relates to economic issues, healthcare. It is very difficult to negotiate, one, cost of living adjustments from the employer, and the employees are paying these huge increases. Granted, the employer is paying 80% of that premium increase, we're paying 20. But just to make up for the employees' 20% share, just to break even, you need to get, half, or 1.5%, 2%. Just for that. So it doesn't need much for everything else. So it's why our unions are pushing this and other issues to control healthcare costs, and we appreciate the committee's help.
Right, thank you.
Let's tell you.
Hi. Devin Green, Vermont Association of Hospitals and Health Systems. We represent all of Vermont hospitals, all of which are nonprofit. And I would say I completely understand about healthcare costing too much and how that's impacts taxes and put pressure on the state employees, healthcare plans and teachers as well. We would like to be part of the solution in all of this. My caution is that in saving, so we have just gotten our 2023 actuals back for hospitals. We have 9 hospitals that have negative operating margins. 4 of those hospitals are not critical access hospitals. So there are 4 hospitals that are not critical access hospitals that have negative operating margins. The total margin for the entire healthcare system in Vermont is $29.5 million. If you take $16.3 million out of that, it will have an impact on our hospitals. At the same time, while this is happening, the state is exploring global hospital budgets. And that is not to say that reference-based pricing is totally antithetical to global hospital budgets, but it is based on a fee-for-service health fee-for-service reimbursement. And so we are looking to limit costs with global hospital budgets. It just feels like there are 2 different strategies happening here. And what will that look like? So we certainly have questions about that, and we would want that to be explored in this as well, because it's all happening at the same time. The global hospital budget decision is 2025, and that gets implemented in 2026. We're also having, under Act 167, hospital transformation, a consultant come in and say what hospitals should be, what services they should be providing where. So it could be, we think this unit should close over here, and we think that there should be this different hospital that does all of knee surgeries or something like that. So how does that also play into that? Because it seems like with these recommendations, the hospital landscape is going to be changing really soon. So I would just say there's a lot of upheaval. I know this feels like a no-brainer because it just means reducing prices. The final thing I'll add is, you know, especially for those hospitals that are in the red, they will have to get that money somewhere. And when prices are reduced on one end, as we've seen with Medicaid, it has to come out another end, which would be commercial plans for small businesses and individuals on the commercial market.
So yeah, we're.
Senator White.
Thank you, Madam Chair. And yes, I'm not in healthcare. And this is a bit of a jumble.
Yeah,
Sorry. That's okay. I was like,
I feel a bit of a jumble too,
I-
everything that's going on in healthcare.
yes, it's very confusing. Where does the money go now? Like, so the red section of where what you're basically saying is that, so we saw that lovely graph, it showed us the red percentage that doesn't, it's, there's no understandable reason why there's the cost.
It's 10 years old. That
Okay, well,
information was 10 years old.
Okay, sure,
And the Green Mountain Care Board has been in effect for 10 years.
okay, that's a whole nother, so you're disputing that that is the correct graph?
I would say it needs to be updated.
Okay, let's say they update it. And there's still some red. Like not a ton of red, it's a small amount of red. Where does that go now? Or where did, in what, because what I think I hear you saying is that money is being used. And if you took it away, we would have less things. But what I'm confused about is where is it going now? Because it's not paying for the person who's doing the work. It's not paying for the materials, and it's not related to the location or any of that. It's just like you get what I'm saying? Like it's.
I get what you're saying, and I wouldn't say that it's not paying
Yeah,
for the materials or the location or anything like that, but I would say if you look at a more updated graph that the Green Mountain Care Board presented back in 2021, what it found was that there was less price variation and that there was more cost shift. So
Yeah.
I am happy to provide that information, but basically you see a sea of red in terms of the amount that's being reimbursed for Medicaid and Medicare, and then a lot of green for commercial insurance, because that's hospitals are cost shifting the commercial insurance funding to pay for what's not funded by Medicaid.
Right.
And then it's also cost shifting within their own organizations to pay for labor and delivery or pay for other services that don't get reimbursements.
Okay, so I see what you're saying. Like, it's not like the procedure in and of itself may not cost that amount, but the money that the procedure makes is being used to subsidize other procedures, I guess, or other
Yeah.
things.
Because the
Okay.
reimbursement.
Yes,
rates are
I get that. I still think we should look into it.
Yeah, and I understand and I understand the pressures you're under. I'm just providing my concerns. And again, I would want the study to. If that jumble that you talked about is our lives right now, so
Yeah, you
I
see, you're
wouldn't-
feeling overwhelmed and it's
I
like, this
wouldn't
isn't
want
enough.
this study to be done in a silo on today's world. I would want it to be forward looking in terms of what's happening. Moving ahead.
Yeah, like I said, welcome to my life.
Well, it's a balance. We're always balancing competing goods, right? We want our hospitals to stay open, but we can't afford them the way business is being done now. And we are under reimbursing them, both Medicare and Medicaid, Medicaid most egregiously. But they constantly have to shift because it's not paying enough,
Yeah, no, I get
and it's
that.
not like, anyway, it's a competing
Yeah,
goods.
so
also-
what we're, I'm sorry, Doug, go ahead.
Just one more, so like also with these recommendations that are coming out from the consultant about where services should be provided. If you take away a service from one hospital, but you also reduce the rate for a different service at the hospital. That the service that was taking away from maybe subsidize that
Yeah,
service.
right.
Then like, again, we just can't have competing initiatives happening.
Yeah, and one hospital will be knee surgery hospital, one hospital will be elbow surgery hospital. I think I'm getting it.
That's happening, actually.
I would be really curious, one, to know which hospitals are operating in the red. And while I think it is incredibly important that we talk about cost shifting, I also think it's really important that we talk about, and I'm not even full all of the executive salaries, but the $40 million in executive hospital salaries. And I haven't even gotten to the end of it. I still have 11 more to add.
In Vermont?
Yeah.
So I do think that there is under reimbursement, but I also think there is a pretty exorbitant measure of compensation that hospital executives
Well,
get.
I
that
will
we also
say,
have to
I will
account
say one thing, reference pricing would get at that.
No, but I think that we need to
Exactly.
look at them in conjunction and not simply look at like, oh, well, then we won't be able to pay more. There is another alternative, and that is that we think about who we're paying what.
And I'll say that all of our hospitals, again, nonprofit, so they're controlled by boards of people who are volunteering from their communities to sit on the boards, and they make those decisions about paying them.
Yes.
not.
Or I think that we're missing part of the conversation if we're not talking about. And again, I still have 11 hospital executives to add to my $40 million.
And I just wanna bring the committee back to what our ask was today, thank you, Devin. Which is, we got a request, it's in our committee because it involves the state employees, and the, state healthcare plan. I wanted to, see, what the committee thinks. We did include it in our budget numbers before we were able to take testimony on it because of the timing. This language that is presented, we would have to do a significant rewrite of. But after hearing the sort of thoughts, what are your thinking, and this would what it is us making a decision on whether we want to stick with our recommendation to the appropriations committee. And then they're gonna ultimately decide whether they're gonna put it in the budget. So, yeah, that's where we're at right now.
I don't know who wants to start,
You can start, Senator.
but I think that Devin, I don't think our getting this data is gonna, that it has to be implemented. I think it isn't gonna impact your challenges immediately. I think it will update the data, which is a good thing. So I support this proposal and keeping it included in the budget and spending $15,000. Because all we'll do is get the report and then we have to decide what to do with it. So that is when I think we have to weigh our challenges that you present to us. But I think we can't do anything until we have the report.
Senator White,
Ditto.
Senator Yoski,
I'm very supportive.
Okay. Well, I'm gonna see if I can work with, I will talk to our friends next door and work on this language with Nolan and Jen, if we're gonna move forward with something and see if we can come up with something that will work, cause this probably won't work. And I hear you, Devin, about trying to integrate it into the other conversations, 167 and all that. So I can probably get that language in here so that it's not done in a vacuum. Great. Yeah. Because you're absolutely right, the landscape is, right now, it's changed
Shifting.
significantly
Oh,
based on law that we passed 2 years.
Yeah.
So I wanna make sure that what we pay for doesn't become immediately irrelevant. And so I will see what I can
That would
do.
be
I just
good.
wanted to hear what the committee's thoughts were. Thank you, Mark and Adam. Thank you, Devin. I'm glad you stepped in. I should have invited you as somebody. And I think we're done for today.